From the JAMA Network, this is JAMA Oncology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Oncology.
Hello, and welcome to our listeners around the world. You are listening to JAMA Oncology Author Interviews. Thanks for joining us. I'm Vivek, Subbiah, medical oncologist and clinical trialist and chief of early phase drug development at the Sarah Cannon Research Institute, Nashville, Tennessee, and also the JAMA Oncology podcast host for today and the web editor for JAMA Oncology. In 2018, the Nobel Prize in Physiology or Medicine was awarded to Drs. James Allison and Dr. Sasaku Honjo for their pioneering work in cancer therapy through the inhibition of negative immune regulation. Their research has paved the way for novel treatments that harness the power of the immune system to fight cancer. Today, we'll be focusing on two remarkable immunotherapeutic agents, Ipilimumab and Nivolumab, and their potential impact on brain metastases in melanoma, an area with significant unmet medical need. Join us as we explore the science, the promise, and the challenges of the therapies in the fight against one of the most formidable cancer complications. Today, it is my pleasure and honor to introduce Dr. Michael Postow from the Department of Medicine, Memorial Sloan Kettering Cancer Center, New York City, New York, USA, who is the lead author on the paper, Intracranial Outcomes of Ipilimumab and Nivolumab in Melanoma Brain Metastases following progression on anti-PD-1 therapy. Dr. Michael Postow, can you please introduce yourself?
Thank you, Dr. Subbiah. My name is Dr. Michael Postow, and I'm the chief of the Melanoma Service at Memorial Sloan Kettering Cancer Center in New York City. It's my pleasure to talk to you today about our research findings as recently published. Thank you for your interest in this paper.
Congratulations on the paper. Let's talk about understanding the study's impact. Can you explain to the broad listeners the significance of your findings regarding the intracranial efficacy of Ipi and Nivo in patients who have progressed on anti-PD-1 therapy? How do these findings contribute to the current landscape of treatment for melanoma brain metastases? To our audience, we'll be referring Ipilimumab as Ipi and Nivolumab as Nivo moving forwards.
I think the main issue is as we all take care of our patients, we know that brain metastases are such a dreaded complication for many different cancers, lung cancer, kidney cancer, and particularly in melanoma where we encounter this quite frequently. Fortunately, the combination of Ipi and Nivo has shown really great results for brain metastases in that prior prospective trials have shown response rates of approximately 50% in patients with brain metastases. But the issue is that we had previously not known how effective this combination is in patients that have had prior PD-1 based immunotherapy. And so our study that we recently published was looking at the efficacy of Ipi-Nivo combination immune therapy in patients with prior PD-1 exposure. And therefore, we found that in the setting of prior PD-1 exposure, Ipi-Nivo was not nearly as effective as it would be in the settings of PD-1 naive melanoma treatment. And we think this is really important because in the clinic now in melanoma, many of our patients are receiving neoadjuvant PD-1-based treatments or adjuvant PD-1-based treatments, and they later go on to develop brain metastases. And so, although this was a single-center retrospective analysis of a modestly sized group of 28 patients, it's really important, I think, as the first demonstration of the efficacy of Ipi-Nivo in brain metastases in this particular clinical context, which I think will continue to be increasingly relevant as more and more people have prior PD-1 prior to development of brain metastases.
So what were some of the key challenges you faced while conducting this study, particularly in terms of patient selection and data analysis? How did you address these challenges to ensure the integrity of your results?
With every retrospective project, it's really hard to go back and characterize things exactly as would have been characterized in prospective trials. And we wanted to look at the efficacy of Ipi-Nivo in the same way as much as possible as Ipi-Nivo was evaluated in prospective trials. And without the whole team of people that are always involved with prospective trials, I think that was one of our biggest challenges, to do our analysis as much as the trials had done. And every time you do retrospective research, it's always more difficult to go back and see what happened and try to follow the patients in the exact same way. So I work with a very talented team of investigators And I give them all the credit in the world. Dr. Sarah Loughran, who's also the primary author on this paper, did a lot of great work on that. And adjudicating the brain melanoma responsiveness, I think, was one of our biggest challenges in looking back and adjudicating how we could retrospectively account for the efficacy of this combination approach. And I think she did a great job putting this all together with all the available information that we had.
Thank you so much. So let's talk about the clinical implications. So how do you see your findings influencing clinical practice, especially regarding the use of local therapies like radiotherapy alongside immunotherapy in this patient population?
Because the efficacy that we saw was not as high as we would have expected from the prospective trials where patients had not had prior PD-1 immune therapy, I think that brings in the idea that it's really important to engage in a multidisciplinary fashion with your radiation oncologist that might be able to offer stereotactic radiosurgery, or neurosurgical colleagues that might need to resect a brain metastasis when we're thinking about treating brain metastasis in this particular clinical context of prior PD-1 exposure and progression. It's not enough to rely exclusively on Nivo plus Ipi in that setting, because the response rate that we saw from Nivo Ipi alone was lower than we would have hoped for. It's about 14%. But the bottom line is, although Nivo Ipi is still one of the more effective treatments intracranially from a systemic therapy perspective, it's really important to know that that's not going to be enough, and we have to do something more for patients with brain metastases in that setting. Whereas in the PD-1 naive setting, maybe it's reasonable to start with Ipi-Nivo a little while and see how that might work, because the efficacy is much higher.
Thank you. So let's talk about patient outcomes and quality of life. Beyond the usual survival metrics, how did your study address or consider the quality of life for patients undergoing treatment with Ipi and Nivo? Are there any patient-reported outcomes that you think should be included in future studies?
I think patient-reported outcomes are critical to include, and understanding how patients perceive receiving only systemic therapy, or they perceive the need and experience of undergoing treatments like surgery or radiotherapy. That's really important to understand, because as much as we can treat patients effectively without them having to undergo all these additional modalities that have time and effort away from work, and of course, a lot of anxiety sometimes with some of these additional treatment modalities, that's as best as possible if we can try to understand that a little bit better. In our study, it was difficult to retrospectively look at the quality of life in these patients because we didn't prospectively use patient-reported outcome instruments or otherwise. The toxicities of Nivolumab and Ipilimumab are generally well known, and those were resembling classic Ipi-Nivo side effects, so there was no kind of additional signal of concern, which was very reassuring. But I do think, as we think about multimodal treatment of brain metastases, radiation, surgery, systemic immunotherapies, teasing out how patients might feel and experience some of these modalities, I think, is a huge area of unmet need, and we need to understand that better. And I think that's an area for future research.
Well said. Thank you so much. I think it's very, very important that we focus on, patient outcomes and quality of life. So let's talk about future research directions. Given that your study emphasized the need for larger studies, what do you envision as the next steps for research in treating PD-1 resistant melanoma brain metastases? Are there any particular areas or hypotheses you believe should be prioritized?
Because Nivo plus Ipi and PD-1 refractory melanoma doesn't have the highest intracranial efficacy, I think it sets a bar that we need to surpass. There are many theories of ways that we can try to increase the efficacy. We have triplet immune checkpoint blockade that's coming forward in melanoma, and we're starting to explore combinations of LAG-3 blocking antibodies, PD-1 antibodies, and CTLA-4 blocking antibodies. So maybe triplet checkpoint blockade could be one way to circumvent some mechanisms of resistance to standard combination doublet blockade. We have studies in the melanoma field of new cellular therapies and the first FDA approval of tumor-infiltrating lymphocyte therapy. How well that works intracranially in settings of PD-1 progression is also a really big area of interest, and the melanoma field just completed the first prospective evaluation of lifileucel, which is our tumor-infiltrating lymphocyte therapy for patients with PD-1 resistant melanoma brain metastases. So there are whole new areas of melanoma drug development, cell therapies, bispecific antibody therapies that are coming forward, triplet checkpoint blockade, that I think we are hoping to close that gap in efficacy that we're currently seeing in brain metastases and trying to really take care of our brain metastases patients in ways that we know to be different biology is going to be helpful moving forward too.
Thank you so much. So any final thoughts for our broad audience of JAMA Oncology? Any key take-home points from your paper?
I think clinically, the paper says we should think about radiation and or surgery in combination with Nivo-Ipi for patients with PD-1 resistant brain metastases. And I think it's a reminder of, despite the successes from the 2018 Nobel Prize and all of the survival improvements we've had in the melanoma field with drugs like PD-1 blocking antibodies and Ipilimumab, we have a long way to go, and we can never rest until we really get to 100%. And I think this identified a patient population of unmet need that we need to really double down on our research efforts. And I look forward to advances in the years to come.
Thank you so much. I'm Dr. Vivek Subbiah, and I've been speaking with Dr. Michael Postow about the science, the promise, and the challenges of novel immune checkpoint therapies in the fight against one of the most formidable cancer complications, intracranial outcomes of Ipi and Nivo in melanoma brain metastasis following progression on anti-PD-1 therapy. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.